Welcome to North County Business in Focus. I'm Ted Owen. And today's show is an inside look at one of the fastest growing specialties in the medical industry these days, and that's surgical weight loss. We'll be right back after this timeout to talk about that. Welcome back, and welcome to Dr. Julie Ellner, if I get this right, Medical Director of the Alvarado Surgical Weight Loss Clinic. Would be close?
Alvarado Surgical Weight Loss Program.
Clinic program. Well, okay. Anyway. It's a long business card title. Before we get into what that's all about, because I think it's a very interesting field. First of all, I'm quite interested in how you got into it, first of all, because doctors in most consumer minds have only one, they're general practicing family physicians or OBGYNs or something, and this is quite an interesting specialty, I think. But before we do that, share with the viewers a little bit, if you don't mind, where you grew up, where you went to school, and how you got to be here with us today.
Patients ask me that all the time. I grew up in a little tiny town in Nebraska named Funk. About 150 people, 2 streets with a couple of cross streets. And I declared my pre-medical major when I was about 4. So my whole life, I've wanted to be a doctor, and there's really never been anything else that I've wanted to do. I didn't go through the normal stages of wanting to be a ballerina or the president.
Fire person.
Or fire person.
Yeah, right.
Or even a nurse like my mother, but I did have a lot of early exposure to physicians and nurses because my mother was a nurse.
What did your dad do?
I'm sorry?
What was your father's vocation?
My father worked for the railroad, Burlington Northern Railroad, that courses from Colorado east to Iowa, and he was in charge of most of the lines between Colorado and Iowa.
Oh, that was good.
So I had a lot of early exposure to the field of medicine through my mother, and after school and during summers, I used to just spend the time in the clinic where my mother worked, sitting in a corner like a little mouse, just watching the doctors and the nurses work, and I always just had a fascination with it.
I've always been fascinated by it, but I don't think I could ever be a practitioner of it, only because of the other people's blood. I mean, there's a whole lot of stuff that goes on. But
well, when I was very young, I used to operate on the animals that my cat would bring into the garage, and I had my little operating room set up in the corner of my garage when I was about 7 or 8.
So that's like when I was in biology school, we were dissecting frogs.
Right. I look forward to that day.
You look forward to that day. So why did you decide, young girl going off to college, why did you pick Tufts to go to medical school? There's hundreds of medical schools.
I had always wanted to go to medical school on the East Coast. I graduated from a college in Philadelphia, and to me, Boston was just the mecca of medicine, of old boy, old time, lots of history there. I'm very interested in history and the history of medicine, so it was just natural that I wanted to go to Boston to medical school. I really didn't know if I was going to get in because it was a very competitive program, but I was very pleased to get into Tufts. So I spent 4 very pleasant years there.
Just out of my own curiosity, what was the ratio of students, males to females?
Interestingly, it was kind of a pioneer program. It was 50-50.
Really?
Mm-hmm.
I always envisioned 100 medical students, of which 10 are female and 90 are male for some reason.
That's the way it is in the field of surgery. But in our medical school, it was 50-50, but it's generally not.
Okay, so you graduated from that program and you did your residency in Iowa.
At the University of Iowa, so I went back to the Midwest for my residency. It had a very strong history of general surgery training, and the role model, if you will, for me when I was a child was a general surgeon who lived in a town about 10 minutes away from Funk, and he was a surgeon that basically operated on everybody for every reason. He was the only surgeon for 50 miles in any direction, and he had gone to medical school at the University of Iowa, so I had some connections. Plus my family caregiver when I was a child, my pediatrician basically was from the University of Iowa too.
So it's something like the Doc Hollywood movie.
No.
Nothing like that. No.
Now it's a little more like Doc Hollywood now that I'm in San Diego.
All right, so you go to do your residency and you become a general surgeon. So let's talk about how you got into what we're identifying here as surgical weight loss. Bariatric surgery and programs, I don't know how long they've been in, but as a historian of the industry, you'll certainly tell us that. But isn't it sort of a new phenomena for people to, in the last couple of decades?
It's more popular, but it's not necessarily new. The grandfather of surgical weight control is Dr. Ed Mason, who happens to be at the University of Iowa. Oh. So it was my affiliation with him that really kind of generated my interest in surgical weight loss. Now, he was doing a different procedure back then, versus the gastric bypass, which is what we're doing now, the gold standard. But he's been doing these operations and designing these operations since the 1950s.
So you learned from the master. I mean,
I really did.
Yeah.
He is the grandfather of doing open bariatric surgery, which is through a bigger incision. Then I came to San Diego and trained with the two men who invented the laparoscopic technique to do the gastric bypass. Laparoscopic
so
meaning,
typically they, instead of the bigger incision, you said we do, how do we do the other?
the traditional or older type of operation is done through a large incision,
Right.
typically from the bottom of the breastbone down to the belly button or down to the pubic bone. The same operation is performed through tiny incisions with a camera inside that goes in through the belly button via the laparoscopic route. Laparoscopic just means same operation, different incisions. So the operation is done the same way on the inside by the time you get to the end of the case.
Well, forgetting the cost comparisons, because they're probably pretty similar perhaps, but what's the difference for the patient as far as recovery? And
There's a tremendous difference for the patients. Initially, laparoscopic surgery was driven by the patients and demanded by the patients because they felt so much better, the pain was significantly less, they got back to work weeks sooner, basically just got back to their regular daily activities sooner and took a lot less pain medicine and could interact in their normal daily activities sooner. But then as we performed more and more laparoscopic surgery, we found out from a medical standpoint that there were many advantages because a lot of the complications occur less frequently with the laparoscopic technique versus the big open incisions that we used to do.
I think that's probably going to be the case for future surgeries. A lot of the recovery period is control of bacteria and infections and rejection and I guess and things like that. But okay, let's go to the beginning. What is the classic patient like? Does their practicing physician end up referring them to you? So how do you get involved with the patient and vice versa? How do they get involved with you?
Interestingly, most of my referrals come from other patients. We have a very sophisticated patient population. Most of my patients have done research on their own with or without the help of their physician for months or years before they come to me requesting a gastric bypass. So most of our patients don't get immediately referred by other physicians. They find out about it from friends or from reading on their own in the bookstore, in the magazines. Then they go online typically and look on the internet and get more information there.
So diets don't generally work. They're short-term fixes. You can lose 10 or 15 pounds and feel good and gain 20 pounds without watching.
That's right. That's right.
My doctor, my cardiologist in particular, I asked him about my annual physical. I said, "Now, what kind of diet really works? Atkins, Palm Beach, West, whatever it is." Mm-hmm. He goes, "Ted, there's only one diet I can guarantee on writing that will work." And I said, "What is it?" And he says, "If it tastes good, spit it out." So I thought that's me.
Fat makes things taste good.
Yeah, right.
That's true.
So dieting is okay for some, but not normally.
That's right.
One of the other wives' tales that I'd like you to dispel is a overweight, obese, large, whatever the word is, person is not driven by double-decker cheeseburgers most of the time. So
right.
Give us the profile of a typical patient that you see.
The typical patient that I see is someone who is reasonably active, has tried multiple regimens of diets, medications, physical activity. A lot of my patients have been to personal trainers trying to lose weight, so they've been struggling for many years in an effort to lose weight. By the time they get to me, they feel like they've exhausted other efforts, and this is kind of their last ditch effort to try to save their lives to lose weight. Most of my patients are very active in their jobs, very active in their families, and they come to me wanting to exercise and wanting to be healthier. In fact, I have 3 former patients who are now competitive triathloners.